Hey everyone, in this lecture video, I'm going to talk about the pacemaker system of the heart, and we'll also touch on electrocardiograms or EKGs, and we'll end with a short discussion on cardiac output. So let's just start by talking about the pacemaker of the heart, which is really the sinoatrial or SA node. This is where the autorhythmicity of the heart comes from. So these pacemaker cells spontaneously depolarize, creating a rhythm for the heart. The SA node is located on the right atrium and it is connected via internodal pathways to the AV node. So when the SA node depolarizes, that message will be communicated via the internodal pathways to the AV node. The AV node is also autorhythmic, so while it responds to the SA node, it also is capable of maintaining its own rhythm. Although the AV node is a little slower and a little weaker than the SA node, so it can't be a full-on replacement for the SA node, but it can be as a backup system, if you will, for at least a short period of time to keep the heart going. Messages received by the AV node for contraction or systole will travel down the AV bundle. You'll see that there's the moderator band coming off of that AV bundle branch heading into the right ventricle. And then also those AV bundles will eventually become Purkinje fibers that will deliver that message out to the cardiac muscle cells of the ventricles. So we get this nice coordinated contraction of the heart, starting at the atria and moving down into the ventricles. Now, we can measure that electrical activity, right? So we have this depolarization happening in the SA node and moving along the conducting system. So we can put monitors or leads on people and we can record those electrical events using electrodes on the skin surface. So essentially we can assess the SA node and the conducting portions and the actual contractile components of the heart based on the reading of those electrical events in an EKG. So what we're going to look for to read an EKG is we're going to look for the P wave. That should be our first small wave on the EKG. It represents depolarization of the atria, and immediately after depolarization, we should have atrial systole or contraction. Then we can look for the big QRS complex. It's pretty dramatic looking. This is going to represent the depolarization of the ventricles, and then the ventricles will contract sort of immediately after that R wave, because you always have to have depolarization before you actually get the contraction. And then the last little bump we'll see is the T wave, which represents the depolarization. Let me catch that. That should not say depolarization. That should say repolarization. Autocorrect got me there. So the T wave is repolarization of the ventricles. And the QRS complex actually hides or masks the repolarization of the atria. So the atria are also going to repolarize. We just can't see it on the EKG because the QRS complex is so big, it masks that. So let's take a little peek here. There's our P wave. So that little bump right there is depolarization of the atria. Then we're going to have that QRS complex. This is representing depolarization of the ventricles, and we're going to have systole of the ventricles right in this area immediately after R. And then we're going to see repolarization of the ventricles right here as the T wave. And again, the atria did also repolarize, but it was happening right here, and it gets covered up by the QRS complex because the ventricles are so much more, they're bigger, and this event is much bigger. And so it's going to mask that. So any change to this pattern would indicate that something is a little bit off. So for example, here's our normal pattern over here, like we just looked at. But up here, we could see premature atrial contraction. So that is when the atria are contracting before they should. And so there's our normal pattern, normal. And then all of a sudden, we see the T wave here and then no pause. We get an immediate P wave indicating premature atrial contraction. Not a huge deal, typically speaking. And they happen every once in a while. In a premature ventricular contraction, now it's the ventricles that are going to contract too soon. So here's our normal pattern. And then you see here's a T wave. And then notice there's no P wave after that T wave. Instead, we just get an immediate ventricular contraction. So it came on too soon. We're missing the normal pattern there. Again, this is not the end of the world. It does occur in people occasionally. Now, if you get ventricular tachycardia, that means you're getting that ventricular contraction over and over and over again very rapidly without any P waves. And so that's going to look like this. This is an issue, right? This is not a good sign, and it suggests something is not right and we need to intervene. And if we have this mess down here, this is ventricular fibrillation. It means the heart is basically like just quivering and it's not pumping. This is a major concern and indicates cardiac arrest. All right, let's watch this quick video that will go into a little more detail on some of these issues.
Welcome to another Anatomy and Physiology Smart Art video, where we guide you through an important piece of art. After watching this video, you should be able to describe the conducting system of the heart and the electrical events shown on an electrocardiogram. Let's begin by looking at this image showing the heart and its conducting system, a network of pacemaker cells and conducting cells. An electrocardiogram, or ECG, also known as an EKG, measures the electrical activity of the conducting system. Let's move to step 1. Each heartbeat begins with an action potential generated by the sinoatrial, or SA node. The SA node is a cluster of pacemaker cells embedded in the posterior wall of the right atrium. In step 2, the action potential travels along the conducting cells of the internodal pathways and spreads across both atria. We see this depolarization of the atria as the P wave on an ECG. In step 3, the action potential continues to the pacemaker cells of the atrioventricular, or AV node, located at the junction between the atria and the ventricles, and can be seen as the PR segment. At this time, atrial contraction actually occurs. Now let's move to step 4. As atrial contraction completes, the impulse moves along the interventricular septum within the conducting cells of the AV bundle. The right and left bundle branches to the Purkinje fibers, as well as the moderator band and the papillary muscles of the right ventricle. In step 5, the Purkinje fibers distribute the impulse throughout the ventricular myocardium, causing the ventricles to contract. We can see this ventricular depolarization on an ECG as the QRS complex. Ventricular contraction, however, begins shortly after the peak of the R wave. The atria are repolarizing at this time, but the repolarization is masked by the QRS complex. To summarize, the heart's conducting system consists of the pacemaker cells of the SA and AV nodes and conducting cells of the internodal pathways, AV bundle, bundle branches, and Purkinje fibers. The electrical events of the conducting system can be seen on an electrocardiogram, with the P wave representing atrial depolarization and the QRS complex corresponding to ventricular depolarization. Remember that the atria actually contract during the PR segment. The ventricles contract shortly after the R wave peak, and the QRS complex masks atrial repolarization. Notice in this ECG tracing the T wave, which represents ventricular repolarization. So what? Why is it important to understand the heart's conducting system and the electrocardiogram? Well, this knowledge is crucial to detecting and diagnosing cardiac arrhythmias, abnormal patterns of the heart's electrical activity. Cardiac arrhythmias can be caused by drugs and hormones, a heart attack, or for unknown reasons, and can range from temporary and relatively mild conditions, such as premature contractions of the atria or ventricles, to life-threatening, as in ventricular fibrillation, when the ventricles quiver and are unable to eject blood. Many other cardiac arrhythmias are possible, and treatments range from medications to the surgical implantation of an artificial pacemaker to regulate heart rate.
Alrighty, so that might all beg the question, how do we control heart rate if the SA node is the pacemaker of the heart? Well, it is the pacemaker of the heart, but your brain does have some tricks up its sleeves. You might remember from AP1 that the medulla oblongata has a whole bunch of centers that regulate lots of things, including respiration, but also heart rate, and they're called cardiac centers. So the autonomic nervous system, remember parasympathetic and sympathetic. Parasympathetic is like rest and digest, and sympathetic is like fight or flight. So the parasympathetic nervous system can slow the heart rate by making it harder for the cells in the SA node to depolarize. They take the cells further from threshold, which is going to slow the heart rate. On the other hand, and that would be acetylcholine is the neurotransmitter involved. On the other hand, the sympathetic nervous system can increase the heart rate by bringing the cells of the SA node closer to threshold, making it easier for them to depolarize. And so norepinephrine will be the neurotransmitter that has that effect. Over here on the right, you can see graphs of that hyperpolarization. So the parasympathetic nervous system is taking the cells further from threshold, which decreases the likelihood of depolarization, which slows the heart rate down, versus norepinephrine in the sympathetic. It's bringing the cells closer to threshold, making them more likely to depolarize, and so we see an increase in heart rate. Normal heart rate at rest is between 60 and 100 beats per minute. And this little graph down here is just demonstrating that, and how if it gets faster, we call that tachycardia. And if it gets slower, we call that bradycardia. Now, the one last piece we want to have some ideas about is cardiac output, because how much blood gets out to your peripheral tissues is really important, because your peripheral tissues, the cells of your body, they need to get enough blood to receive the oxygen and glucose that they need to carry out their functions, and also to get rid of all of their waste metabolites from whatever functions and chemical reactions they've been carrying out. So your body has to maintain homeostasis of cardiac output. We want to make sure we're getting adequate blood flow to all the cells in your body. And there's two things that contribute to cardiac output: heart rate, how many beats per minute. So if we want to move more blood out of the heart, we can just make the heart pump faster, right? So that will get more blood out per minute. Or we can increase the amount of blood exiting the left ventricle going out into the aorta. That's called stroke volume. We can increase that. That would also increase cardiac output. Or we could do both, and we could dramatically increase cardiac output. So two major factors, heart rate and stroke volume, will determine cardiac output. And your body has the ability to adjust or alter either or both of them. So stroke volume is the amount of blood, or the volume of blood, that exits the ventricle and either heads off to the lungs if we're talking right side, or heads out to the body if we're talking left side. So to determine that stroke volume, we're going to have to take the difference between the volume of blood that went into the ventricle versus what was left in the ventricle after contraction. In other words, when ventricles contract, they do not eject all of the blood out into the pulmonary trunk or the aorta. Some blood gets left behind. So that's not part of the stroke volume. So we have to take that into account. So we got to know how much went in and how much was still in there after contraction in order to figure out what the actual amount of blood was that exited the ventricle. So we have end diastolic volume. That's how much blood went in. And then end systolic volume. That's what was left in the ventricle after contraction. And if we can figure out those numbers, then we will know stroke volume. How can we alter stroke volume then? Well, we can alter end diastolic volume or end systolic volume, right? We can either put more blood into the ventricle to increase stroke volume, or we can get more blood out of the ventricle to increase stroke volume, potentially both, and that would really increase stroke volume. So end diastolic volume is venous return. How much time do we allow the heart to fill? So the longer it's relaxed, the more blood can fill the atria in the ventricles during diastole. that would increase end diastolic volume. But that also means our heart rate's probably kind of low in terms of beats per minute. End systolic volume is all about contractility. So, can we squeeze harder and get more blood out, or can we squeeze less hard and not move as much blood out? So, for example, beta blockers reduce contractility, so it's going to decrease cardiac output. All right, so let's look at all the things that might impact or help regulate heart rate and stroke volume and therefore impact cardiac output. So over here on the left, I'm going to just blow this up a little bit. We've got factors affecting heart rate. So we've got this atrial reflex, which just is adjustments in the heart rate in response to an increase in venous return. So when the walls of the right atrium are stretched, that's going to stimulate sympathetic activity because it means we've got larger volumes of blood coming in. So we're going to need to increase the heart rate to move that blood out, right? There may also be hormones that increase heart rate like epinephrine and thyroxine. Think back to chapter 16 in lecture. And then also body temperature and exercise, right? Your heart rate is going to rise with either increased body temperature and it will lower with a drop in body temperature. And if we change the heart rate, then that will change cardiac output. Sorry, it's not letting me. Here we go. It will change cardiac output because if we increase heart rate, we will increase cardiac output. If we decrease heart rate, we will decrease cardiac output. So that's all about beats per minute or heart rate. But over here, we're looking at stroke volume. Well, some of the same things will also impact stroke volume. So things like exercise, muscular contraction is going to compress veins and assist valves in directing venous blood back to the right atrium. Well, that means that we are going to end up with that atrial reflex, right? And that's going to increase heart rate. Large reductions in blood volume, though, due to bleeding or dehydration, is going to decrease that venous return. So then we're going to see a slowing in heart rate. And then we also, any kind of change in peripheral blood flow patterns can increase or decrease how much blood is coming back to the heart, which in turn will impact the atrial reflex. So in general, when venous return increases, stroke volume will increase because more blood is coming into the heart. And when venous return decreases, stroke volume will decrease because there's less blood coming into the heart. We could allow more time to preload to get a higher EDV, which will stretch the myocardium, and that may also lead to more end systolic increases as well. And then over here, some factors that are specifically going to affect stroke volume. We have the autonomic nervous system. We can have the sympathetic stimulation can increase both heart rate and contractility. Remember, contractility is going to squeeze more out on the ejection, whereas parasympathetic can slow the heart rate, but it doesn't have a lot of influence on contractility. Some hormones can increase contractility to get more blood out during or after ESV. And also we can think about how we can have the heart pumping more efficiently. So this is a huge piece of like cardiovascular improvement. Like if you haven't been exercising and then you decide you're going to train for a marathon, a huge part of what you're doing is exercising your cardiac system in order to be better at pumping blood, right? So you want to increase stroke volume without always, really upping your heart rate. Like you want to find that perfect medium where, yes, your heart rate goes up, but you don't want it beating like crazy. So to try to get the blood out to the muscles that you need for that running that marathon, you're going to increase your stroke volume. So, and that takes practice and exercise and training in order to do that.